And I like first to know if you can hear my voice. So I would appreciate it if you let me know. Can you please raise your hand or send me a message? Thank you, Ahmed. Thank you, Anna. Thank you all. With that said, let's move on and address today's lecture. Essentially, some of you actually attended this lecture before, but because it exceeded the 2 hours limit, was almost about 2.5 hours, because I welcomed some questions, so I wasn't able to process it and place it for you on YouTube. So the intention today is essentially to break it down to 1 hour apiece. So we're going to meet from 2 to 3 Eastern time, 2 to 2:50, and then 3 to 3:50. With that said, let's move on and address endocrinology module. I already introduced myself to you. My name is Dr. Henry Zeidan, and you have a couple of lectures on pharmacology, one on biochemistry, and this one will be an endocrine system. So I intend to proceed with global medical education to help professional students to do very well at USMLE exams, various other standardized exams, those who applied for diplomate status in clinical chemistry, others at various standard exams. The second sequence will be on global health education, how to be your own doctor, achieve and sustain a healthy lifestyle. So I intend to proceed with these activities. I already set a sequence of classes for global medical education. So next week at the same time, you will see me here. We're going to interact in pharmacology lectures. I like to proceed intensively in pharmacology and then shift my gears toward endocrine system, physiology, and biochemistry. Endocrine system is the most significant section actually at USMLE exam. So you do expect to see, roughly speaking, about 35% of the questions devoted to the endocrine system. Why is that? The examiner is interested actually to see to what extent the student can differentiate between primary and secondary disorder diseases. So with the first lecture, I will acquaint you first with the endocrine system. And we're going to cover essential terms, essential mechanisms of actions that addresses all hormones. Be able to define some terminology that you need to appreciate and understand fully before you move on and address classes. You have to have an appreciation on all of those terms before we move on. And as you recall, in order to address endocrine system, we have to deal with first with the normal physiology, and then we addressing the pathophysiological aspects. In the recent years, USMLE exams concentrate on pathophysiological aspects. So in numerous cases, we're going to address the physiology first, followed by the pathophysiological aspects. Occasionally, we're going to coincide with both of them together. One of the most significant parts that you need to understand on the endocrine system is the feedback regulation. The examiner is interested to what extent you really appreciate this mechanism as an effective way to control the production of a hormone and to be able to differentiate between hypersecretions versus hyposecretions. With that said, let's move on and address some of the key objectives that we like to achieve for today's lecture. First, we're going to address terminology. What's meant by the endocrine system? What's meant by a hormone, a ligand, a small molecule that can be a modified form of an amino acid, can be a peptide, can be a hormone, can be a protein in structure sense. A receptor as a complex glycoprotein that function as a recognition site for a hormone, that function as a recognition site for a neurotransmitter, that can act as an enzyme complex that certain hormones, drugs can act on it, an endocrine effect that can take place at a site far apart from the site of the hormone secretion, or at its own production. A target cell that constitute the house for those receptors, and an endocrine gland that have numerous cells involved. We like to be able to sort out possible pathways of transmission of hormonal action. We like to be able to compare and contrast the two major mechanisms of action when a hormone binds to a specific receptor site located on the cell membrane versus a hormone that binds to an intracellular receptor site. What are the properties of those hormones? And what is the objective and the effector that's produced out of this interaction between a hormone and a receptor? Those two mechanisms of action, we will discuss it in some detail in order to appreciate the free form versus the bound form of a hormone, in order to appreciate the concentration of a hormone in plasma, in circulation, and the factors that govern this concentration. So as I stated before, you should clearly understand the principle of feedback regulation of hormonal stimuli. You should clearly understand the role of hormones, ions, and substances in different control mechanisms. When we address those receptors, we're going to deal with two classes of receptors. Membrane receptors that follow a second messenger systems. We're going to subdivide those second messengers into subclasses: cyclic AMP, cyclic GMP, phospholipids, calcium, phosphatidylinositol, versus nucleus receptors that deals with protein synthesis. So this will be your target here, and this is where we're going to slow down, compare and contrast among those two classes in detail, and give some exceptions to certain hormones. The last section will be devoted to classification of hormones based on the chemical structure or on the anatomy involved. And then finally, we're going to address bridges between endocrine system and pharmacology versus pathophysiological aspects that deals with hormonal function. Please keep in mind that we addressed actually molecular signaling when we address pharmacology. That's the second lecture of pharmacology. So we address in detail ion channels, adrenergic versus cholinergic drugs, and we dealt with that. So perhaps in future I'm going to integrate those two together. When you look at the term endocrine system or endocrinology, you have to appreciate the fact that a hormone is a chemical substance, actually. It can be in a form of a modified form of amino acid, peptide, or a protein, function as a ligand, and have a strict hormonal regulation of metabolism. When you disturb the system, you expect to see hormonal abnormalities and diseases associated with this hormonal abnormalities. So in a logical sense, the endocrine term refers to internal secretion of biologically active substances when you compare it with exocrine, where you deal secretion outside the body, like sweat glands, for instance. As the term implies here, and as I stated, a hormone is a chemical substance. Chemical substance can be an amino acid, it can be a peptide, it can be a protein. Exist in a very low concentration in blood. The levels of their existence in blood in a free form will determine their effect. Their effect or their regulatory effect on a specific organ, a tissue that can be far apart from the site of their secretion. That's the endocrine effect. When you deal with the endocrine system, you're dealing with two classes you're dealing with paracrine action versus autocrine action. As the term implies here, paracrine action, that's when a hormone acts upon adjacent or surrounding cells. Very specific examples for that you should keep on your hard drive is 6 hormones, 6 steroid hormones in the ovary. The way luteinizing hormone, estrogen, prolactin function as a team. Angiotensin 2 in the kidney. And of course, somatostatin, which is produced from delta cells of the pancreas and tends to act as a modulator to ensure inhibition of secretion of both insulin and glucagon. Insulin from the beta cells and glucagon from the alpha cells. So it acts as a tuning device to ensure a steady state level production of the two opposing hormones. And we can see this nicely in the next 2 figures. That's a paracrine effect. And autocrine, as the name implies here, it's a self-regulation mechanism. The hormone can act on its own cell to inhibit its own production. And the best way to explain that is the insulin inhibition. So insulin does have an inhibitory effect on its own secretion by beta cells. Let's enjoy those 2 figures that I established for you here. And I missed to give you the introduction that I actually prepared a textbook on molecular endocrinology and was very well received by several publishers and was accepted for publication by Jones and Bartlett Publishing. So let's enjoy this presentation here. So you see the endocrine system, production of a chemical substance at the hypothalamic gland level, that tends to have an effect on production of a second hormone from the pituitary gland, and that will be addressed in numerous slides to come. Travel and has receptors on a specific glands that are far further apart from the site of their production and can show an effect on adjacent cell, versus autocrine self-regulation mechanism by which actually the hormone can inhibit its own production. And as I stated, insulin can be considered a good example for that. So you have the text very well explained here in the ligand of the figure, and I already addressed that to you. Let's move on and address the examples that we illustrated as a paracrine effect. So you can see again, alpha cells will tend to produce glucagon in the pancreas. Beta cells will tend to produce insulin, and somatostatin is produced from delta cell. So somatostatin here acts as an effective modulator to inhibit both the production of insulin from beta cells and glucagon from alpha cells. So this is a good example for this type of interaction that take place with those hormones. Let's move on. And address receptors. Let's move on and address endocrine gland. We already mentioned it's a gland that has numerous specialized cells and tends to secrete those hormones. When you look at a receptor, as I stated in pharmacology lecture, in nature, a receptor is a glycoprotein that binds with a great specificity to a hormone, binds with a great specificity to a neurotransmitter. So when you think about receptor, you have to appreciate they are the site of binding to specific hormones, specific neurotransmitters, specific drugs. Some of the receptors themselves, as we addressed, can be enzymes. Any small molecule binds to a large molecular species. We refer to this as a ligand, and we refer to this action of binding as a ligand binding. When you look at the classes of receptors here, you're dealing with two classes of receptors. Cell surface receptors that binds effectively with water-soluble hormones that follow a second messenger mechanisms versus nuclear receptors. Those receptors are located on the nucleus that binds to lipid-soluble hormones that tends to help to synthesize proteins versus cell surface receptors that tends to help modulate second messengers. This is a very basic, important concept that you need to appreciate it before you address the pathophysiological aspects. And of course, target cell that has those receptors. Now, let's address this type of relationship between a hormone and a receptor. You have to keep in mind that the effects of particular hormone can be recognized essentially by a specific receptor. Glucocorticoids binds to a glucocorticoid receptors. But on the other hand, you also should accept the fact that several hormones can have the same effect when they bind to the same receptors. A very good example for that is cortisol, that tends to produce a strong glucocorticoid and is considered a glucocorticoid hormone versus mineral corticoids like aldosterone, for instance. Mineral corticoids have some weak, when you look at the biosynthetic pathway of aldosterone, so you're producing a weak glucocorticoid hormone. So therefore, you accept the fact that those different hormones can bind to the same receptors, versus two hormones can bind have the same effect, but they interact with different receptors. A very good example for that, glucocorticoids and insulin. So insulin follows essentially tyrosine kinase, receptor, glucocorticoid, follow a specific receptors on the adrenal cortex. Okay, let's enjoy this presentation here. Last but not least, two different hormones can bind to the same receptor, like insulin and insulin-like growth factor, IGF. So this is presented very well to you here. A hormone can bind to its specific receptor to produce an effector, modulate mediator protein, or can bind to two different receptors, as you see it here. And it can have effect on modulator proteins and can show two different effectors versus two different hormones can bind to the same receptor and can have an effect, of course, with preferential production, like glucocorticoid, cortisol as a glucocorticoid versus mineralocorticoid hormone. Let's move on further and understand more and more about this system. Now, what are the mechanisms of action involved? You're dealing here with second messenger. When you hear second messenger, so you are dealing with cell surface receptors located on the cell membrane. You're not synthesizing new proteins. You're modulating the effect via the existence of second messengers. Of course, the first messenger is the hormone. Second messenger is cyclic AMP, so you're dealing here with G proteins involved, GS versus GI, that tightly bound to cyclic adenylate cyclase enzyme to produce cyclic AMP or to inhibit the synthesis of cyclic AMP, can go both ways. Inositol triphosphate IP3, diacyl glycerol, so you're dealing here with phosphatidyl inositol, diacyl glycerol that's produced actually from inositol triphosphate can function as a second messenger. Calcium ions can function as a second messenger. So those are the second messenger effects. When you deal with the second messenger effects, as I said, you're not dealing with synthesis of proteins, you're dealing with modulation to produce cyclic AMP. You're dealing with modulation of proteins by their phosphorylation or dephosphorylation reactions. And the whole significance of this is to produce an effector. The whole significance of this is tightly bound to feedback regulation. So there are two classes of feedback regulation. Positive feedback regulation. This is restricted with very specific hormones. As the name implies here, you tend to overproduce a hormone in certain situations. And a very good example for that is sex hormones, of course. A hormone has biological actions that directly or indirectly can cause more secretion of that hormone. So when you look at gonadotropin releasing hormone, which is produced from the hypothalamus, sends a message to luteinizing hormone and follicle stimulating hormone, FSH and LH, that are produced from the anterior pituitary gland to give a sharp production. So with this mechanism, you tend to overproduce LH during ovulation in the second week, end of second week, and that's what we refer to it as LH surge production. This is the story here. Gonadotropin, which is released from the hypothalamus, have an effect on the anterior pituitary gland to produce FSH and LH, and LH have a positive feedback regulation that tends to enhance its own production. Estradiol here have this positive feedback regulation that helps to achieve LH surge that takes place exactly at the end of week 2 during ovulation. And then after that, those levels suppresses, progesterone gets increased. That's what you see in here in terms of LH surge that take place, roughly speaking, on day 14 of the ovulation cycle. So you see LH, you see FSH here, and you see estrogen level. Versus progesterone that tends to increase after the end of second week during ovulation. So this is the luteal phase here, and this is the follicular phase. So that's about positive feedback regulation. When you look at negative feedback regulations, that's what you expect in normal conditions. So self-regulation mechanism. So insulin is secreted from beta cells, from pancreatic beta cells. Why is that? As a result of increase of blood glucose. Once you accomplish that, once you get the glucose into the cell, once you complete glucose uptake into the cell, so you tend to decrease blood glucose concentration level, and therefore there is no need for production of insulin. So the decrease of glucose in blood, glucose level in blood, will tend to decrease further secretion of insulin. And you see that very nicely addressed to you here. Glucose, amino acids, fatty acids, glucagon, you have to appreciate the reciprocal relationship between glucagon and insulin. An increase in any of those metabolites, an increase of glucagon as an opposing hormone, will trigger the release of insulin from beta cells. Once insulin is produced, once insulin does its job, once insulin enhances uptake of those metabolites, there is no longer need for insulin. This is presented very nicely in this slide. Specificity requirement. Insulin bind to its specific receptor sites, tyrosine kinase enzyme tends to modulate translocation of a specific glucose transport carriers. Those transport carriers will facilitate the process by which glucose can get into the cell. When this process is accomplished, insulin secretion is decreased. You have the text explained exactly what I mentioned in few words. So we refer to this as down regulation mechanism, feedback regulation mechanism versus positive regulation. When you shift the gears and look at upregulation of receptors, how are you going to upregulate the receptors? Either by increasing the affinity of the receptor toward the hormone. So by increasing the affinity of a receptor toward the hormone, in essence, you enhancing the production of the effector, or by increasing the number of receptors at the molecular level. The term downregulation is essentially suppressing either the number or the affinity of the receptors for a specific hormone or for another hormone. That's a downregulation mechanism. Best way to address downregulation mechanism is in this fashion. You have to accept the fact that all water-soluble hormones tends to bind to specific receptors on the cell membrane. You see those receptors are located here, and then forms a vesicle, and then this vesicle gets digested by lysozyme, and those receptors can be recycled back again to the surface. So with a downregulation mechanism, what you expect to see is that this process will, by this recycling process, you're decreasing the number of receptors on the cell surface. Let's shift the gears and address hormone specificity, highly specific hormone activity, permissive effect, so we can have a clear understanding of those terms. You have to keep in mind that hormones affect cells that has receptors. If you don't have receptors, hormone cannot function. It's not the case with drugs, that certain drugs actually can function without having receptors. So for instance, ACTH, which is produced from the pituitary gland, the reason for its production is produced from the pituitary gland, and does only this in the adrenal cortex, adrenal gland, and in the gonadal tissue. That's LH in the gonadal tissue. You have to keep in mind that binding of a hormone to a receptor very much the same as binding of a substrate to an enzyme, with the exception here that hormone receptors will never be saturated under normal conditions. But of course, you expect to see the same type of relationship between enzyme and substrate, that increasing the hormone can cause the receptor to go through down regulation mechanism and tissue resistance. Okay. Tissue resistance. So that's what the term tissue resistance coming from. Why is that? Because you're decreasing the number of receptors, so they're not available to bind with further hormones, like insulin resistance that take place in type 2 diabetes. The term permissive effect here is a function of a hormone on another hormone. The exact mode of action of this, exact mechanism is not very well understood, and the very best example for that is glucagon and cortisol. So cortisol will have a permissive effect on glucagon for gluconeogenesis to take place. You see the story here about this decent relationship between gonadotropin releasing hormone that's produced from the hypothalamus and facilitates production of FSH and LH from the anterior pituitary gland that function on the ovary to produce estradiol, and we stated the positive feedback regulation involved that leads to LH surge. So you have this slide again presented to you in this fashion. The best way to explain permissive effect is, as I said, the function of cortisol on glucagon. So cortisol have a permissive effect on production of glucose by glucagon. So cortisol stimulates glycogen synthesis. Cortisol stimulates gluconeogenesis that take place in the liver. So cortisol, which is produced from the adrenal cortex here, have this effect on gluconeogenesis in the liver, or glycogenesis in the liver. Let's shift the gears now and address free versus bound forms of hormone. Which one is biologically active? You have to keep in mind the one that produces the effect is the free form. A common USMLE exam in terms of half-life that deals with lipid-soluble versus water-soluble hormones, and you have at the end a decent summary that address both classes. But what you should keep in mind is the effect is coming only from the free hormone. In circulation, certain hormones circulate in both forms, bound and free form. That's the case actually with lipid-soluble hormones. In circulation, hormones can circulate only in a free form, and that's the case with water-soluble hormone. Okay. When I said hormones bound form, I meant here hormones that can bind to a specific carrier. This carrier can be serum albumin, is a common carrier, but it's not limited to serum albumin. You're dealing here with thyroid globulin, you're dealing with cortisol globulin, and you're dealing with estrogen testosterone binding globulins. So it's not only serum albumin, but certain hormones binds to globulins as well. Those are cortisol, thyroid, estrogen, and testosterone. When you address the free versus bound form, you have to keep in mind what is meant by half-life of a hormone. So the name implies here, a half-life of a hormone is the length of time a hormone remains in circulation. What you should keep in mind that water-soluble hormones have a short half-life. Lipid-soluble hormones have a long half-life. Why is that? Because simply lipid-soluble hormone deals with synthesis of proteins, so it takes much longer to produce a protein. When you inject a patient with a lipid-soluble hormone, you should not expect to see the effect right away. Why? Because you're dealing with synthesis of a protein. Versus when you inject a patient with a water-soluble hormone, you expect to see the effect take place in a few minutes. Why is that? Because you modulate the receptor, because you're dealing with dephosphorylation, phosphorylation reactions via those second messengers, via cyclic AMP, cyclic GMP, phospholipase, phosphatidylinositol, calcium ions. Common standard question at USMLE exam. Which one of the following hormones have the longest half-life? When you see this question and you have one of the answers, T4, this is the one that has a long half-life. Why? Because it's in a bound form with globulin. Okay. But of course, if you see another question and it has various lipid-soluble hormones versus one single water-soluble hormone, and ask which one has the shortest half-life, so the water-soluble hormone is the target here. Common standard USMLE exam question. I presented to you here the two forms of a hormone. It can bind to a free form, as you can see it here, addressed very nicely in this fashion. Free form, that's the free form here, versus bound form. So you have the protein here. Bound form, as I said, can bind to serum albumin. In plasma, it can bind to globulin, like cortisol, like thyroid, binding globulin, or like estrogen, testosterone. What you need to keep in mind that on the target tissue, the one that gives you the feedback inhibition is the free hormone, not the bound one. The one that shows the effect is the free one. When we address the classes at the end of hormones, lipid soluble versus water soluble, we can address also the exception of that. So you can see what I'm talking about here. Okay, like for instance, adrenal androgens They are lipid soluble, but they circulate. They considered actually water soluble in terms of you have a sulfate group that covers them and makes them water soluble. Okay. You have to keep in mind that the term free versus bound relate to the molecular complexity of the hormone. So of course, the more bulky the hormone is, the longer the half-life. So that with those helpful hints, you can actually address those questions easily. You have to keep in mind the exceptions that do exist in terms of circulation of hormones. You have to keep in mind that lipid soluble hormones, due to their nature, they cannot circulate as lipids in an aqueous environment. So they must be carried by a protein carrier. What's the nature of this carrier? As I said, serum albumin globulins with respect to cortisol, testosterone, and estrogen, and thyroid hormones. You have the text here explains that in some detail, and I don't believe that I left out anything without clearly presenting to you. You have this appreciation. You have to keep in mind that the bound form do exist in equilibrium with the free form. And a theoretical, hypothetical example for that, when you really look at it, when you really consider that cortisol can exist in a bound versus free form, thyroid hormones T4 and T3, T4 is a bound form, T3 is a free form, and this type of equilibrium exists. So suppose under hypothetical situation where the liver actually produces more of the hormone, or the liver produces more of the protein that bind to the hormone. So that is globulin. So suppose you overproduce globulin. So you tend actually to suck up all of the free form of the hormone, and you achieve a transit condition. So hypothetically, you expect to see that the patient suffer from severe hyposecretion. But this does not really take place. Keep in mind that they are in equilibrium, and therefore if there is a need for the free form to take place, so the equilibrium is favored toward the right direction. Last but not least, before we take a break, we talked about circulation of hormones, secretion of hormones. Let's talk about destruction and clearance of a hormone. You can destroy hormones by metabolic destruction, by the tissues essentially. The destruction can take place in the liver through proteases enzymes or conjugation to water-soluble substances. And the destruction also can take place by the kidney, and that can be excreted in the urine specimen. So with that, we have essentially the basic principles that you need to follow on it. And normally I give here some clinical cases in a traditional USMLE review course, and I avail the opportunity for discussion, team activities. So let's break at this stage, and when we come back, we can talk about mechanisms of hormone action. I do like to limit the break only to 5 minutes if it's possible, because I do have to go to a funeral arrangement at 4:30, so I like to leave early. But please sign up immediately for the second hour, because I tend to finish this up and avail this to you. And the second part here, if it's not equivalent in its significance to the first part, it will be more significant. So I like to see you all here, and I like you to invite actually additional students to join us in the second hour. I see you in 5 minutes, folks, and I let you enjoy the music again. Thank you all. And I will process this right.